Let's talk about some of the strategies that hospitals are adopting in response to some of the challenges that Heinz mentioned there. And this is based on some work that I've been doing with the European Observatory and with WHO's Regional Office for Europe on NC, the challenge of non-communicable diseases and how hospitals are responding to those. 30 or so years ago, people were predicting the end of the hospital. I saw just the other day someone from the European Union make a similar prediction. But actually, hospitals on the whole are, while they're getting smaller, apart from in Korea, not quite sure what's happening in Korea, the hospitals are looking quite robust, but they are changing. The number of people being admitted to hospital is falling slightly, but there are big opportunities, as you can see here, in asthma and COPD, to reduce hospitalisation still in many countries. Particularly, we have here in the east of Europe some extremely high hospitalisation rates. Length of stay continues to fall. So a pattern of looks like gradual change, but underpinning this is some very, very substantial challenges. You heard a long list there, but big changes in the patterns of disease, in policy direction, within medicine, and in the workforce. And ageing is, of course, often cited as the big challenge, and indeed it does represent a significant challenge. Europe is going to see a growth in its very older people of over 23% in the next 15 years. And we see globally this challenge, particularly in Latin America and the Caribbean, absolutely enormous increases in older people. But the real challenge in many places is not aging so much as multimorbidity. This is data from the UK, where we're expecting a number of people with 4 or more diseases to almost double. Many of those extra diseases are going to be quite serious and intractable, and particularly will have mental health involvement. And we're seeing a particular increase in multimorbidity in the very old. And indeed, we're starting to see a decline in life expectancy at age 75. And this is a result of success. We've been very good at keeping people alive, and the consequence of keeping people alive is they're having longer periods of illness in the last few years of their life. So the years of disability-free life expectancy are not increasing at the rate we hoped. And up to 40% of the increase in emergency demand that we're seeing in hospitals in the UK is a consequence of increased survival. We're keeping people alive to be able to readmit them at a later point. So a great success, but a significant challenge. Here's some similar data which shows an increase in the number of patients with multiple conditions, increasing from 1 in 10 in 2006 to 1 in 3 in 2015-16. The challenge here is that we've organised our hospitals on the basis of single diseases. The patients are increasingly failing to match the way that we have organised our services. We have too many narrow specialists and nowhere near enough general physicians. It's become very unfashionable to be a general physician. The consequence of this is it's great if you've got one disease, but you may well have a serious problem if you have more than one. And this, to some extent, explains the growth in the very rapid growth in hospitalists, the group of internal general medicine specialists in the USA. So our services don't fit demand. We've also seen a very interesting increase in interest in integrated and personal care due to, I think, a feeling that we've been failing people in terms of our ability to personalise what they want, to recognise the social factors that drive demand. There's an economic argument for better, more patient-focused, person-focused care, and there's very definitely an effectiveness argument, which is more integrated, personalised care is more likely to be effective, not least because it reduces the fragmentation that we've got in the system. Within medicine itself, the pressure to centralise is leading to the regionalisation of many more specialist services, partly driven by a hope that there are economies of scale. I have to say the empirical evidence for economies of scale in healthcare is not very strong, but there is, as many of you will be well aware, a strong evidence base for improvements in quality coming from increased volume, from learning effects, from getting teams to work together and having a critical mass of work that allows you to have a senior doctor on site, a major predictor of post-operative survival. But it's largely related to procedural specialties, to people doing interventions. It's not so clear that in heart failure or pneumonia or other internal general medicine that scale is so important. The bigger driver is often the economics of being able to run 24-hour rotas, requiring you to have increasingly large populations, with a number of specialist societies in Europe now recommending big volumes, big population sizes as the minimum size to be able to run, for example, a vascular surgery service. Heinz mentioned a number of these other issues. I won't run through them. You'll all be familiar with the challenges in the workforce, particularly around burnout, which is a big issue, but also in rural areas. It's increasingly difficult to recruit anyone to rural areas. And then there's these other opportunities of technology. In the wider environment, we still have ministries of finance who suspect that hospitals are a major source of inefficiency and simply want more money and are very suspicious about any attempts to have increasing resources going into the hospital sector. So hospitals have a job to do to explain how they fit in to the changing landscape in a positive way. And let's have a think about what some of that might include. So the standard response is an efficiency improvement response. We can reduce length of stay, we can make procurement savings, we can use lean or other redesign methods, we can reprofile the workforce, we can change the skill mix of the inpatient staff. This is all pretty well understood, and I suppose what we would say is that this is simply now the price. Being very good at this is simply the price of staying in business. There's nothing special about your ability to do that. Everyone needs to do it, and we need to get much slicker at how you involve frontline clinical staff in the redesign of processes and systems. So let's move on from that and think about how hospitals need to start to think about being in more horizontal networks with other types of hospitals. And there's a variety of these. We'll have a quick look at some of them in a minute. But most of this really asking the question, what is the set of core services that we need to be able to deliver to our local population, and what linkages do we need to other providers that will increase our capability, allow us to provide better services more locally, but without having to necessarily sustain a very large number of independent specialist services. So the most common model would be a sort of hub and spoke model with a division of labour between the spokes, which might be smaller hospitals or ambulatory care units, and the major centres. So in colorectal cancer, we would expect the hub to be doing radiotherapy, running histopathology services, the management of complex metastatic disease, the development of standards, and more complex imaging. For example, PET-CT. The spokes, high volume, they're doing screening, scoping, they're doing imaging, they will do biopsy, they will do surveillance of patients in remission, there will be a base for chemotherapy and provide rehabilitation, and the management of the complications of chemotherapy such as neutropenic sepsis, and they will be the coordinators of end-of-life care. So division of labour, but a set of standard processes across the system. In trauma and stroke, we see the development of more, and indeed obstetrics, tiers of service depending on the capability of each of the units with well-defined escalation criteria. And in the case of trauma and stroke, ambulance services that are able to identify which patient needs to go to which part of the tier. And in obstetrics, criteria such as age at gestational age at delivery being one, and other risk factors like diabetes, for example, being criteria for whether patients are escalated up the system. Again, the feature of this is standardized processes and systems and a very clear understanding of how each bit of the network fits together, what the expectations are. A very significant problem in many systems is the need for smaller hospitals to negotiate with the major centre to have their patients transferred. In these sorts of models, you operate a call and send model. You put the patient in an ambulance and you notify the tertiary centre that the patient is coming. You don't ring up the tertiary centre and spend 2 hours trying to persuade them to take the patient. A big feature in Germany, France, Belgium, perhaps in the UK, certainly in the US, and in India as well, is the development of hospital groups of various types. Some of them are geographically close together, but in the field of planned care, they may, in South Africa, for example, they may be spread right across the system. They make savings by having shared back office and purchasing, standardized policies. There's that common feature of many of these models. But the operating units have high levels of autonomy on business choices. The interesting thing here is that the leadership skills required to run these organizations are very different from the leadership skills required to run a hospital. So running a group seems to be different from the skills needed to run a hospital. They're growing quickly, and of course, they tend to have very strong financial balance sheets. So I suspect that we will see them continuing to grow, and they tend to grow by acquisition and merger. Rather more rare is a sort of non-hierarchical network bound together by a shared pathway or set of guidelines. A really interesting example I point you to is the Parkinson's Net model in the Netherlands, where accredited providers are chosen by patients, and the care is given according to a standardized pathway, and the patients can navigate their way through this system. That the role of the tertiary centre in these models is a setting of standards, of audit and of quality management, rather than being the manager of the network. So some important lessons in all of this, which is the mergers and acquisitions needed to develop more formal networks, such as the hospital groups, are really tricky to do. They require a great deal of skill, and they often fail. The task of building more informal networks where, for example, the tiered networks or the hub and spoke models, if there isn't shared governance, requires the development of trust and a set of incentives which require a significant investment in terms of time to develop the systems, but also to develop the relationships and trust between the members of the group. All of these network models require the managers of hospitals to develop some new skills and capability to be able to bind together different ways of working, to persuade clinicians to operate on more standard approaches to the transfer and management of their patients. The third response is a similar type of networking model, but in this case to take the hospital and make it part of an integrated care system, either as a partner with other providers in the system, as the owner of an integrated system, like the Montefiore system in the Bronx in New York, or as lead institutions in a wider, more informal network. This is very attractive, but does require very substantial changes both to the business model on which the hospital operates and the way it's paid. because the common model of payment by DRG-based payments doesn't work for integrated types of care delivery. It's also got some quite significant implications inside the hospital because it will, if it works, change the nature of the patients who are admitted. They will be more acutely ill, and the inpatient staffing model required to deliver that will also need to change. One of the most interesting things from my perspective is what this implies for some of the specialists who deal with non-communicable disease or are specialists in older people's care or indeed in children, and sort of rethinking the role of the specialist as a population health focused specialist whose job is not to sit in a clinic and see patients or to just walk around the ward and see the patients in the wards, but to be the co-producer of pathways and guidelines with the patients and local primary care professionals, to be their educator and advisor and to keep the system up to date with the science, to provide support to specialist nurses and other and care coordinators in the integrated systems locally, to deal with the most complex patients, but in a more proactive way, so calling them in rather than waiting for them to be referred, and taking a population health view using registries with primary care, identifying the high-risk patients using risk stratification models, developing population health interventions, and for quite a few chronic diseases, understanding the context and social environment in which these patients live, and working with their family doctors to help to deal with that. You could even imagine a population health-focused orthopedic surgeon, which may stretch your imagination. But again, you could see how if you run a system in which, for example, all of your musculoskeletal patients are assessed by physiotherapists according to protocols, that you actually don't need preoperative assessment by orthopedic surgeons. And we have examples in the UK where the patients referred by physiotherapists to an orthopedics clinic, 95% of them are then listed for surgery. In other words, the judgment of the allied health professional in determining who needs surgery can be very accurate. So the surgeons can spend more of their time operating. They don't need to see their patients if you assess their patient-reported outcome, measure their pain. The patients can initiate follow-up, so we can reduce the number of follow-ups. They can adopt shared decision-making processes to ensure that a knee replacement is really what you need, as opposed to exercise, non-steroidal anti-inflammatories or mobility aids. And they could start to get involved in more preventative programs. So redefining the role of the specialist seems interesting. If you're going to change the way the hospital works with the system, primary care needs to change too. It needs to scale up. You can't operate an integrated model with 30 different models of primary care, all operating with 2 doctors and 1 nurse and an administrator. They need to be on a bigger scale. They need a different staffing mix. They need better access to diagnostics than is available in most parts of Europe. And they also probably need to shift from primary care being predominantly a face-to-face business to one where at least 50% of it is done by telephone or web, which is achieved in places in the world, but there are big opportunities. And primary care needs to change alongside the hospital. And hospitals can help with that, although the experience of hospitals taking over primary care to run it is not very encouraging. There are some examples, but it turns out to be difficult to do. So a number of changes flow from this, certainly very different outpatient models, one that's more based on advice and guidance to primary care, with more clinics being done virtually, on paper, or perhaps not on paper, digitally, asynchronously, in other words, reviewing the patient information without necessarily having the patient there with you, or having the patient on the end of a telephone sitting with their primary care doctor. We might also think about a shift to more multidisciplinary clinics for symptoms and more one-stop diagnosis and treatment. The hospital also probably needs to outreach more into its community to ensure better rapid discharge and step down in that continued search for efficiency. And there's a great deal more that hospitals can do to improve end-of-life care, to reduce the number of people who actually die in hospital rather than in their own homes. And in the Netherlands and in the UK, we've seen some very interesting innovations with hospitals reaching into care homes to improve the medicines management, to identify patients who need interventions and support, to train the staff, and to develop end-of-life care plans so that patients don't spend the last 8 hours of their life waiting for a bed in the emergency department when they should have been in a nursing home. So changing the end-of-life model is really important. Some other responses that we see in other places, so definitely opportunities to redesign the skill mix and to extend the role of nurses and to ensure that we have more of our staff working at the top of their license by careful redesign of their work, which in many countries requires some very substantial regulatory changes which need to be lobbied for. It sort of goes without saying that we'll need digital capacity. I almost don't need to say that. But the big opportunity here perhaps is to use it to support more proactive management. We tend to focus on how digital will improve the transactional components of healthcare. The big opportunity, it seems to me, is to use the data that we generate to identify the patients who need earlier intervention and call them in rather than waiting for them to come as emergencies. And also perhaps to shift more work to patients, to empower the patients to undertake self-management and self-service, and a bit beyond the self-check-in model to something that's more about patient empowerment. The whole topic there, which we haven't time for. All of this, I think, and across many countries, the emergency front door of the hospital needs completely redesigning. It's often not fit for purpose. There is insufficient early medical intervention in the front door, and in many countries, there's more than one front door. I think Germany has multiple front doors to many of its hospitals. So rationalising of the front door, more multidisciplinary approaches to frontline management, and improving the ability of emergency services to process patients effectively and efficiently in a short time. The other big change, I think we'll see increasing development, certainly in Scotland and elsewhere, of factory models and standalone planned surgery units, and a big change with interventional radiology substituting for some other areas of work. Other big opportunities in diagnostics, particularly the dissemination of diagnostics through the hospital, but also more into primary care, and more, where we haven't got centralised laboratories, we'd like to see a combination of more centralisation of laboratories, but also an increase in point-of-care testing. And then the final thing that I think hospitals ought to be thinking about in terms of response to this, and in particular to the sustainability agenda, is to get the hospital to be a more active part in its local community in many places. They are often the biggest employer. They're a big purchaser of potentially big purchaser of local goods and services, and they are a very large producer of carbon. So how does the hospital work with local organisations, with local government, to help to build the economy, to train and develop staff locally, particularly in rural areas where people are starting to establish medical schools and nursing schools in rural areas to try and deal with some of the workforce challenges that we've got, and to work to improve the lives of local citizens, patients and staff as major players in their local systems rather than distant castles on a hill or outside the town. So all of these potential strategies, and they're not mutually exclusive, they can all be done, but they do have significant implications for the leaders of hospitals, and in particular for their leadership and management skills at achieving change and getting clinicians to think differently about how their services are provided, and to give those clinicians the support and help to make that happen. It also requires a level of planning expertise that is missing in a number of our systems. The biggest challenge of all, where we're very short of expertise, however, is the rethinking and redesigning of the workforce that we will need to do to make all of that happen. There's a very incomplete survey of the sustainability landscape, but I only had 25 minutes, and I've now only got one, so I'm going to stop.
No.
Thank you very much. That's